Good afternoon to everybody. All right. So my name is Molitey, Dombour, and I'll be leading the discussion on today's topic, which is chronic obstructive pulmonary disease, COPD in short. So the outline of the presentation is going to be like this. We have the definition, the epidemiology, the risk factors, a brief pathophysiology of COPD, the clinical manifestations. We'll look at the investigations, differential diagnosis, complications of COPD, the management, and then the references. So as mode of definition, according to the Global Initiative for Obstructive Lung Disease, COPD is a common, preventable, and treatable disease state that is characterized by persistent respiratory symptoms and an airflow limitation due to an airway and alveolar abnormalities. That's to say that it involves both the airways and then the lung parenchyma, which is usually caused by significant exposure to noxious particles or gases. In this case, as we heard from the introductory note, usually commonly seen in people who are smokers or have had chronic exposures to certain noxious particles. So this airflow limitation is usually a slow and progressive process, and then it manifests as bronchitis and or emphysema. That is to say that the term COPD covers two broad entities, that is chronic bronchitis and that of emphysema. As we go, we'll get to see the definitions and then the explanations to these two entities. And then you can have these entities existing on their own or an overlap between the two. But what we see in majority of the cases is a combination of these two entities. So bronchitis is actually a clinical entity. That is to say that the diagnosis is basically clinical. And then what this means for you to say that somebody has chronic bronchitis, it has to be defined in time and space, such that this person should have a mucus-producing cough, which occurs most of the days for at least 3 consecutive months for at least 2 successive years, without other underlying disease to explain the cough. This person should have, as the explanation says, a cough that is mucus producing, variable in quantity and character. And then this person should have had a cough for at least 3 months consecutively for 2 successive years. And then that of emphysema is an anatomical definition where there's an abnormal enlargement and inflammatory destruction of the alveolar walls, the ducts, the septa, the capillaries, and sacs that are distal to the terminal bronchioles. So when you look at the respiratory system or tract, you realize you have the larynx, that is those of the upper airway, the trachea, the 2 main bronchi, which will go into the how do you call them? The terminal bronchioles into the respiratory bronchioles and then into the alveolar sacs. So usually in the case of emphysema, the problem is distal to the terminal bronchioles, that is involving the respiratory bronchioles and then that of the alveolar sacs. Now, as mode of epidemiology, it says that in 2015, about 3.2 million of the world population died from COPD. And then currently, we have about 80 million people who are estimated to be living with COPD worldwide. It is estimated that about 32 million persons in the United States are suffering from COPD, and it is the 4th leading cause of death in that country. Initially, they used to say that COPD was more common in men than women because of the fact that men have a higher propensity to smoke than women. But now we've seen that the statistics are changing. And so there's even an anticipated rise in prevalence with regards to the morbidity and mortality in COPD in the Asian and in African countries as a result of the increase in this habit of smoking amongst the population in these less deprived countries. So in smokers, it says that about 2/3 of men and then 1/4 of women have emphysema at death. And then COPD usually is a condition of mid-age. That is, it's mostly seen in people in their after their second decades, mostly in their 5th and then 6th decades of life. And then if you see anybody who has had a risk of smoking should have at least a pack year of more than 20 years before they have that propensity to suffer from COPD. So meaning that people who have smoked less than that number of years, have had less than 20 pack years without any other associated risk, have a less tendency to develop COPD. And we know that for you to calculate the pack years, you are talking of the average number of packs of cigarette that the person smokes per day, per the number of years that the person smokes or the person has smoked. So as risk factors with COPD, we divide them into environmental and then genetic. And we saw that, from the epidemiology, smoking is the #1 and most significant risk factor in COPD. It could be primary and secondary. Primary as in the person doing the smoking, and secondary as in those having a secondary exposure, or what we call the secondhand smokers. And so for such people, an exposure for a very long time also stand a risk of developing COPD. We also have a prolonged exposure to occupational dust and then chemicals and fumes, like those of our brothers or those people who are into the mining, for example, the gold mine or even the coal mining. We've had a lot of people coming in with respiratory conditions, and then they've also have had the risk of smoking. And so now you are torn between if it's just an occupational lung disease or it's a typical COPD that you are looking at. And also we have risk factors such as indoor pollution from biomass, as Dr. Dominic was saying, that those are mothers who used to cook with the firewood in enclosed environments for a very long time, also have the propensity or the tendency to develop chronic obstructive pulmonary disease. Then people who were born with low birth weights also have the risk because of the poor nature in the development of their respiratory system. Then family history of COPD also predisposes a person. Then recurrent childhood respiratory infections, poverty and alcohol also are factors that can lead one to getting COPD. Now, the genetic factor here is mostly related to the alpha-1 antitrypsin deficiency, which the alpha-1 antitrypsin is just a prototype member of the serine protease inhibitors superfamily proteins. What they basically do is that they inhibit the proteinases from, there have to be a balance between this alpha-1 antitrypsin and then the enzymes or the proteinases that are responsible for breaking down certain components of the elastic fibers, principally the elastin. And so it's a codominant, it's an autosomal codominant, condition with a lot of alleles. And then some literature will state like more than 120 alleles. And so when you look at my presentation, I've written homozygote ZZ. So the pi or the PI ZZ, what it means is that the serine proteinase, which was the commonest type, also called the serpina-1 proteinase. Usually they have different types of alleles. The M allele is the normal one, which means that the person has sufficient levels of antitrypsin in the system. Then you have the Z, where there's a mild, the S, where there's a mild decrease, and then the Z, where there's a marked decrease in the alpha-1 antitrypsin protein. Then we have the null allele, where there's a total absence of the alpha-1 antitrypsin. So if you have somebody who even has the S allele and the Z allele, which is heterozygous, you can still have a disease manifesting, just that it will be mild. And so the commonest type is usually the homozygote ZZ, where there's a marked decrease, in the alpha-1 antitrypsin deficiency, antitrypsin protein. And so, as I said, when there's this disbalance or mismatch between these proteins that are supposed to prevent the enzymes from breaking down the elastic fibers, principally the elastin, then you see a predominance of of the elastases or the proteinases, which result in the degradation of the elastic fibers, principally the elastin, which forms a greater chunk of the lung parenchyma and then the airways. And so going to the pathophysiology, the chronic obstructive pulmonary disease is actually founded on the basis of chronic inflammation. And then this inflammation is actually due to two main mechanisms. One is by activation of oxidation reduction sensitive transcription factors, such as the nuclear KB factor, which bind to and then activate cytokine and chemokine inflammatory genes. And the other one is an oxidative inactivation of anti-inflammatory proteins, such as the alpha-1 antitrypsin. So what it means is that these two mechanisms of inflammation, what they end up doing is that they secrete chemotatic factors, and then such as the interleukin 8 and then tumor necrosis factor alpha and others, which are responsible for attracting inflammatory cells such as the neutrophils to the site of injury as a result of the chronic exposure to the nicotine from smoking. Now, these neutrophils or inflammatory cells, what they do is that they secrete the elastases, these proteinases, which are enzymes that degrade the elastic fiber, principally the elastin of the respiratory and then the respiratory airways and then the lung parenchyma. Now, there's supposed to be a balance between these enzymes that are secreted and then the enzyme or the molecule that is supposed to regulate their function, which is the alpha-1 antitrypsin. So when there's this chronic inflammation ongoing, it means the levels of elastases or proteinases that are going to be secreted will predominate that of the alpha-1 antitrypsin. So you have more degradation of the elastin, and then this would end up giving you the typical picture of the emphysema. That is, there will be destruction of the alveolar septa, the ducts, and then the capillaries that are around it. And so there will be a loss of the pulmonary or the alveolar required. Now, also as a result of the chronic inflammation, there's a hyperplasia and then a hypertrophy with increased mucus production of the glandular and then goblet cells of the respiratory or airway. Now, these injuries, as a result of these injuries, there will be an attempt to repair the injury. And then this will lead to, a distortion in the remodeling of the collagen deposition that causes a fixed obstruction of the airways. Now, as I was saying about the alpha-1 antitrypsin, since it is a protein that is supposed to regulate these enzymes that degrade the proteinases, when somebody has a deficiency of this protein, then there's also a tendency that the person would develop a COPD, especially the emphysematous type. And then it's usually seen in people who have had less pack years of smoking, that is in younger patients or persons, less than 40 to 45 years. And so it causes the type of, pathologically, when you do the autopsy, what the type of emphysema that it usually causes is the pan-ascina, or what they call the panlobular emphysema. And it usually involves the lower airway, the lower portions or the lower lobes of the lungs. Now, this, as I was saying, this permanent destruction of the alveolar walls will lead to a loss of the elastic recoil. And then the smoking is those who have had or who have smoked before will suffer from the centrolobular or centriacinal type of emphysema. And this one usually affects the proximal airways, that's the respiratory bronchioles. And then, and so it's a milder form, and it usually affects the upper lobes of the lungs or the superior portions of the lower lobes. And then the panlobular one, as I said, is usually seen in the alpha-1 antitrypsin deficiency. And so this is more of a picturesque representation of what I was saying. And so going into the clinical manifestations of COPD. So usually the typical symptoms of COPD are the chronic cough, the sputum production, and then the, how do you call it, the dyspnea. And the dyspnea, which initially is on heavy exertion, then it becomes, how do you call it, as the disease progresses, then the person will begin or can develop it with mild exertion. And later, when the disease is at its terminal stage, the person can develop the dyspnea at rest. The sputum production is variable, and then it depends if the person is suffering from an exacerbation or not. And so these symptoms will tend to vary depending on the stage of the disease or depending on other associated or superimposed conditions that could be causing an exacerbation. So you could also have hemoptysis, but we know that in our setting, a patient coming to you with cough, dyspnea, and a hemoptysis, you can't just narrow it down. Even if the person has had or has a risk factor of smoking, you would have to look at other diagnoses. We also have chest tightness, then fever as a result, which would be as a manifestation, a systemic manifestation of other associated conditions or causes of an exacerbation in patients with COPD. Then the edema is usually seen in when you have, as a complication of the COPD, you have what we call the pulmonary, which develops as a result of the chronic pulmonary hypertension that develops from COPD. And so it says that during an acute exacerbation of COPD, the increase in shortness of breath and then the sputum production or change in its character or frequency of the cough and confusion would tell you if the person is having an exacerbation or not. And then on the examination, so when you see the patient for the first time, they used to describe two characteristic phenotypes in people with COPD, the blue bloaters or the pink puffers. The blue bloaters, they said initially they used to associate it with people with chronic bronchitis, where these persons are people who are chubby, they come in with edema and then cyanosis. And so it means that these are people who are coming in the late stages of the disease where pulmonary is setting in. And then they talk of the pink puffers, usually seen in emphysematous patients because of the fact that these people with emphysema usually do not readily or easily progress to the hypoxemic, hypercapnic state of COPD, and so they still appear pink in the initial stages of the condition. So if these people come in thin in appearance, they can be plethoric, and if the person is still smoking, you can see the nicotine staining of the fingers. There could be bipedal edema as a result of the pulmonary that could develop from the COPD and then cyanosis as well. And so on the respiratory system, you see that these people come in with tachypnea. There's use of accessory muscles, such as the lower chest indrawing. There could be autopnea, and then the typical barrel chest, where you see an increase in the AP diameter of the person's thorax. So there could also be long expiratory phase with expiratory wheeze, and then there's this paradoxical movement of the abdominal wall due to the indwelling of the lower respiratory cage, and then the pursed lips, which is just an attempt by the patient to try and prolong the expiratory phase just to help open up the airways. There could also be decreased chest wall expansion as a result of the hyperinflation of the lungs from especially the emphysematous type, where we know that during inspiration, the airways physiologically tend to open up, and during expiration, they tend to collapse. And so people who have COPD, where there's a chronic obstruction of the airways together with the destruction of the elastic fibers, would have what we call the air trapping, leading to hyperinflation of the lungs. And so these people, when they try to listen, there's so much air trapped in the lungs that the chest wall expansion decreases. So there could also be increased or decreased vocal fremitus. The increased vocal fremitus if the person comes with a superimposed lobar pneumonia, but the decreased vocal fremitus if the typical COPD patient is actually what you find. Then there's also the hyperresonant percussion note with loss of the cardiac dullness as a result of the hyperinflation of the lungs. There could be reduced breath sounds and rhonchi, and then crepitations as a result of of a superimposed lung infection like a lobar pneumonia in the acute exacerbation states. Then in the cardiovascular system, you could find the signs of a right-sided heart failure, which is what they describe as a pulmonary, which usually develops from the chronic pulmonary hypertension from COPD. And so you have these distended neck veins. There could be tachycardia, hypotension, and you could have, an AFib developing from the COPD as a non-cardiac cause of atrial fibrillation. And so the pulse could be irregular. Then, as I said, your raised JVP when you do the measurement, and then your hepatojugular reflux. So as investigations, usually there are complementary investigations that we do to either rule in or rule out other conditions. And then we have the gold standard for the diagnosis of COPD. So the investigation, you will do your FBC. And then on the FBC, you could have elevated HB, which is as a result of the hypoxia. And we know that when there's hypoxia, at the level of the kidneys, erythropoietin is secreted, and this will stimulate the bone marrow to increase erythropoiesis. And this leads to an increase in what we call the red blood cells, which is the hypoxia-induced erythrocytosis or the secondary polycythemia. There could also be leukocytosis with differential of neutrophilia, especially if they have a superimposed lung infection such as lobar pneumonia. And then the ABG, that is the arterial blood gas, usually in severe conditions, you would have a decrease in the partial pressure of oxygen, and then an increase in the partial pressure of carbon dioxide with a decrease in your pH. So in that case, you might be you'll be seeing this a picture of a respiratory acidosis if the other compensatory mechanisms haven't set in. So you can also do an ECG, and on your ECG, you can see signs of right heart chamber enlargement, such as your typical P pulmonary, where you see an accentuation of the P wave, that is a hyperacute P wave. There could also be a sinus tachycardia and a typical multifocal atrial tachycardia, which is as a result of the hypoxia. The pacemaker of the heart, which is the SA node, tend to slow down, and so the other foci of electrical discharges from the atria, and so you can have this typical arrhythmia coming up, which could be picked on the ECG. And in our setting, it will be prudent to do a sputum for gene aspect just to rule in or rule out an associated PTB. And then you can also do a chest X-ray, but on the chest X-ray, you won't see any reliable sign of severity of the disease, but it will give you a picture of what you are dealing with. And so on a typical COPD patient, what you find on the X-ray, you have hyperinflated lungs, you have flattening of the diaphragms with increase in the intercostal spaces, and there could also be peribronchial and perivascular markings. Then the chest CT scan, the high resolution type, could also help you to determine the level of destruction of the airways and that of the lung parenchyma, such as the formation of the bulla, because we know in the epistemimatous type there's destruction of the alveolar septa, and so there's coalescence, there's merging of multiple alveoli, and then to form a single one, which is usually what they describe as the bully. And then you can also pick up a PE as a result, and we know that the secondary polycythemia that develops from COPD, and these patients stand a chance of developing PE from the hypercoagulability, coagulable state that can arise from the secondary polycythemia. And then you can also use it to rule out other differentials such as a lung CA. And then you can also do a measurement of the alpha-1 antitrypsin, and it's usually recommended if COPD occurs in patients less than 40 to 45 years. And so this is an X-ray of a patient who had COPD, where you see flattening of both hemidiaphragms, with increase in the intercostal space and flattening of the ribs, and then the peribronchial and then vascular markings. And so the gold standard for the diagnosis of COPD is actually a spirometry. And then the spirometry provides objective information about the pulmonary function, and it assesses the response to therapy as well as the disease progression. And so for you to be able to assess the disease progression objectively in a patient with COPD, it's actually recommendable to do serial spirometry. And then a person is said to have COPD when on the spirometry, there is a post-bronchodilator FEV1, that is the forced expiratory volume in 1 second, is less than 80% of predicted value. That is for the age, the sex, and the height. And it's also accompanied by the FEV1 and then the FVC, that is the forced vital capacity ratio of less than 0.7, and if expressed in percentage, 70%. So your lung volume measurements will also reveal an increase in your residual volume and then the total lung capacity, and an elevation of the residual volume and the total lung capacity ratio. And so these are graphs to illustrate what I was talking about. So you see your forced expiratory volume in the first minute. That is on a normal spirometry on the left, where is 4 liters, and then that of the forced vital capacity is 5 liters. So when you find the ratio, you realize that it's equal to 0.8, which means that the person has normal spirometric values for a lung function. And then on the right, you have that of the obstructive disease, where you have the ratio less than 0.7. On the graph is 0.56. And so we are before a patient with COPD. And then it's usually post bronchodilator because you actually are supposed to do pre and then post. And then the post in the chronic obstructive pulmonary disease, there's actually no, how to call it? There's complete irreversibility of the obstruction. But, and that will also help you to differentiate it from other chronic, obstructive pulmonary disease, such as the asthma. In the case of asthma, when you apply the bronchodilator and then you repeat the spirometry, you realize that there is a reversal of the obstruction. And then that gives you the picture of if you are dealing with a typical COPD or you're dealing with an asthma. And so assessing the severity of the disease, you can either use the how do you call it, the spirometry, or use clinical scoring. And then the 3 scoring tools that they use, we have the spirometric classification of the COPD severity based on the post-bronchodilator FEV1. And then you have that of the modified Medical Research Council dyspnea scale, and then that of the COPD assessment test, that is the CAT. And so the second, that is the MMRC, and then the CAT are more of clinical assessment or scoring of the severity of the disease in patients with COPD. But the spirometric classification is more, will give you a better picture because that one is more objective. And so this is the spirometric classification of COPD. So it's divided into 4 stages, where stage 1 is mild. And then in all the stages, one thing is that for once you've concluded that a person has COPD, it means that the FEV1 and then FVC ratio is less than 0.7. Now, the severity is actually dependent on the degree of decrease in the FEV1 values, that is of predicted for age, sex, and height. And so the stage 1, where you have the mild one, you have your FEV1 FVC ratio of less than 0.7, and then the FEV1 greater than 80% of predicted, greater than or equal to 80% of predicted value, which will tell you that this person has a mild disease. In the moderate stage, the FEV1 is between 15 and then 80% of predicted value. And the severe and the very severe, the severe one, you have that between how do you call it, 30 and 50. And then the very severe one, you have the FEV1 falling below 30%, which means that the person could or is going into chronic respiratory failure. And now, as I was saying, this is the CAT system, which is more of a clinical scoring, where you look at the comparison between I never cough and then you give a score, and then the other end you have I cough all the time. So depending on the symptomatology of the patient, you give a score. And sometimes it's actually difficult because these are subjective. What you might be expecting to hear, the patient might not give you that. And so you are tempted to score based on what you think the patient is saying. And so the best tool actually will be to use the spirometric classification. That is the gold classification for the severity of COPD. This is the modified Medical Research Council Dyspnea scale, where it's from 0 to 4. And so, sorry to go back, the CAT assessment scale, if you have somebody with a score of less than 10, it's a mild disease, and a score of more than 10, it indicates severe disease. And that of the modified Medical Research Council Dyspnea scale, if you have a score of 2 and above, that is a marker of severity of disease. And if it's less than 2, then that is a mild disease. And then, so the differential diagnosis of COPD, one of them is basically in our setting, you would have to make sure that it's not asthma. And so we know that asthma usually is a disease of childhood. What it means that it usually sets in the early stages of life, even though we have adult onset asthma and then other occupationally associated asthma. But from your history, you'll be able to tell that this person has had or has been having the symptoms from childhood. The other thing is that asthma is associated with other, findings such as atopic dermatitis. There's always a history of atopy, allergies like allergic rhinitis, and then, these associated symptoms. And so once you have a patient coming in, even if it's an elderly person, and then you take your history properly, you realize that this person has been having these recurrent episodes, which are actually variable. It's not like COPD, which is almost like a constant, symptomatology that the patient presents with. The other condition that you have to rule out is congestive heart failure. And then, of course, people with congestive heart failure will come with dyspnea. They will equally have autopnea, and then you have your paroxysmal nocturnal dyspnea, together with other findings that could help you also narrow in or narrow out on the congestive cardiac failure. And then the other one is bronchiectasis. Bronchiectasis, actually, some literature would consider it as a complication of COPD, which is usually a permanent dilation of the airways. And so these patients will equally come in with symptoms of obstruction, but their mucus production is usually voluminous, and then they have the typical, POP smell, like wet POP smell when they come in with the history. And then the other one is tuberculosis. And we know that, as I was saying, our setting, a patient coming to you with dyspnea, sputum production, and then hemoptysis, the first thing that comes to mind as a clinician is always PTB, because of the endemicity of tuberculosis. And so your sputum for gene aspect and then your chest X-ray, even though it's not too specific, it wouldn't give you specific findings, but they will help you to actually rule out or rule in on COPD. Then you also have the obliterative bronchiolitis and then the diffuse panbronchiolitis. Now the complications, as I was saying, you have bronchiectasis, the cor pulmonale, and the cor pulmonale is usually as a result of the chronic hypertension. We know that hypoxia at the level of the lungs causes vasoconstriction of the lung capillaries. And so when it happens like that, the right side will have to pump against a higher resistance. And this will lead to hypertrophy. We know when the heart works against resistance, it develops, the musculature of the heart will undergo hypertrophy. And so with time, this heart will begin to fail. And that's where you have your typical cor pulmonale. So now what happens is that if, for you to be able to, the gold standard for the diagnosis of cor pulmonale is the measurement of the pulmonary capillary wedge pressure using the Swan's-Ganz catheter. And then you can also have the spontaneous pneumothorax developing from COPD as a result of rupture of any of the epiphysematous blebs, usually the periseptal ones, which are closer to the pleural space. They can rupture, and then you have a spontaneous pneumothorax. And then arrhythmias, as I said, you can have AFib, your multifocal atrial tachycardia that can develop from COPD. Then weight loss, chronic weight loss as a result of the condition, and the person can also go into respiratory failure. Then the management of COPD is aimed at treating the acute exacerbations, preventing the disease progression, to prevent relapses, and then to preventing the complications. So in treating the acute exacerbation of COPD, it's good to always give supplemental oxygen titrated to maintain a saturation between 90 and 92%. It's advisable not to give high flow oxygen because of the tendency of eliminating, or the danger of eliminating, the hyposemic drive, which would actually tip the patient into respiratory failure. Then one other recommended group of medications that you can use are the short-acting beta-2 agonists, such as the albuterol. And this one you can give 2.5 milligrams dilated with saline to a total of 3 mils. And you can either give via a nebulizer or a metered dose inhaler, which you can give 90 micrograms per puff, 4 to 8 puffs via a spacer, and then as needed. And you can combine it with a short-acting muscarinic agonist, such as that's the M3 muscarinic 3 antagonist. And the one that we use is the ipratropium bromide, especially in our setting. And you can either combine it with the albuterol or the salbutamol. That is what we use in our setting most of the time. Or you can give them separately by a nebulizer. You can also do a short course oral corticosteroids, and then 0.5 milligrams per kg per day. And then we'll get to see why the use of inhaled steroids is not advisable in the acute exacerbation. Then you can add a broad spectrum antibiotics depending on either your sputum cultures or the characteristics of the sputum that the patient presents with. And for patients without risk factors for Pseudomonas infection, it's recommendable to use levofloxacin 550 milligrams per also IV per day, or you can do your third generation cephalosporins, such as the ceftriaxone or the cefotaxime. And then for those with risk for Pseudomonas, you can use your piperacillin tazobactam, or you can do your ceftazidime or cefepime. And so the goals for treatment of patients with stable COPD, you aim at relieving the symptoms, you improve the exercise tolerance, because we realize that one of the scoring systems, such as the COPD assessment tool, focuses more on the exercise tolerance regime. And then we also look at improving the health status and then preventing the disease progression. We prevent and treat the acute exacerbations, which we've looked at, and then to reduce the mortality. And so in treating the stable patient, the best cornerstone or the significant therapies that you can do is to counsel the patients on smoking cessation. And then this could be done by psychoeducation, intensive group programs, pharmacological therapies, using that of the nicotine replacement therapy, such as the transdermal patch or the gum, or you can also do the bupropion therapy. And it is actually advisable to treat such patients for 7 to 12 weeks. And when the symptoms of COPD are resolved, and then you can take them off it. And it's no longer advisable to put patients on the e-cigarette and then the vaping devices, because of there's also an associated lung injury with such, therapies, which is called the e-villi. Then the home supplemental oxygen, what we call the long-term oxygen therapy, is the only therapy actually that has been proven to increase the survival rates in people with COPD. And so these patients who come in with COPD diagnosed with spirometry, it's actually better to put them on supplemental oxygen. And then the benefits actually come when they're using the oxygen more than 15 hours per day. Some literature will say that the benefit is seen when they are using it at least 20 hours per day. But you don't just put every patient on a long-term oxygen therapy. There are also indications for it. And so the indications for it is that when you have a patient who has a partial pressure of oxygen less than 55 on arterial blood gas, or the saturation less than 88% in the absence of acute complicating factors or cor pulmonale, you can start the patient on long-term oxygen therapy. And then those who have the partial pressure of oxygen between 55 and 60, or the saturation less than 89, but have other associated complicating factors, and then the cor pulmonale, you can also start them on the long-term oxygen therapy. And it's actually a low dose, oxygen that you give between 2 and 4 liters per minute, aiming at a saturation of 88 to 92% because of the danger of elimination of the hypoxic drive and then tipping the patient into respiratory failure. And so one of the other main stages of the management of COPD is the use of bronchodilators. As we see, we can either use the, the long-acting muscarinic antagonist or the long-acting beta-2 agonist. You can also use the short-acting and then the SABA. And as we saw, it's basically used in the management of acute exacerbations. That is the short-acting muscarinic antagonist and then the short-acting beta agonist. And so the long-acting muscarinic antagonist is actually what they recommend for the management of the stable patient in COPD because of its effectivity in the management of the condition as compared to the long-acting beta agonist. And so if you have your patient who comes in with your modified medical research council score of less than 2, and that of your COPD assessment tool of less than 10, so you are like in a group A or B, COPD. And so these ones, you recommend the use of either a LABA or a combination of the two. And so once you have your CAT more than 10 or your modified medical research council score of more than 2, so you are dealing with a group C or a group D, together with the number of episodes of exacerbation the patient gets in a year or hospitalizations the patient have had from the exacerbation. And so you are dealing with a group C and a group D. And for a group C and a group D, a combined therapy is actually recommended where there's a combination of a LAMA plus a LABA. And you can either add your inhaled corticosteroids or not, depending on the number of exacerbations, because inhaled corticosteroids have been shown to reduce the frequency of exacerbations by 25 to 30% in patients with COPD. And so these are some of the long-acting muscarinic antagonists that are used, the tiotropium, which are the tiotropium, the umeclidinium, and then rivefenacin, which are used on once daily. And then the ones that are used twice daily, you have the aclidinium and then glycopyrrolate. Then the long-acting beta agonists or the LABAs, the ones daily dosing ones are the indacaterol, the oladaterol, and then the vilanterol. Then the twice daily is the commonest ones that we know, the salmeterol, your formoterol, and then the aformoterol. And so the inhaled corticosteroids that I was talking about, which are actually used to reduce the rate or frequency of exacerbations, are the fluticasone, the beclometasone, and the budesonide and mometasone. And so you can have a combination of the inhaled corticosteroids together with the long-acting beta agonist, which in our setting you have the Symbicort and that of the Seretide. The Symbicort being the combination of the budesonide and the formoterol, and then the Seretide being the combination of fluticasone and vilanterol. And salmeterol. And so as I was saying that we don't just use the inhaled corticosteroids in all patients with COPD. So these are the indications. If a patient comes in with a history of hospitalization from exacerbation of COPD or more than 2 moderate exacerbations per year, or with a blood eosinophils of more than 300, these are patients who have strong support to start the ICS for them. And then you can also consider the use of inhaled corticosteroids if they come with a moderate exacerbation of COPD per year or blood eosinophils between 100 and 300. But we do not recommend it in people who have had repeated pneumonia events or the blood eosinophils less than 100 with history of mycobacterial infection. That is people who could be having pulmonary tuberculosis. And so you could also do, the triple therapy that I was talking about using the two bronchodilators, that is the LABA and the LAMA, plus the inhaled corticosteroids. And so now they have medications that come in that combination as a single, inhaler or nebulizer, such as the Trelegy Ellipta dry powder inhaler, which is a combination of vilanterol, omeclidinium, and fluticasone. And we also have the Breztri Aerosphere metered dose inhaler, where you have the formoterol, the glycopyrrolate, and budesonide combined. But in using the inhaled corticosteroid, it means that you have to counsel the patients and then train the patient on how to use the inhaler. If not, you wouldn't be achieving any effect, because these are devices that are not very common, and then not everybody is familiar with them. So depending on the device that you are using, you would have to counsel the patient and then actually train the patient on how to use it. And then you also have to counsel the patient on certain measures to take after having used the inhaler, because one of the side effects of using the inhaled corticosteroids is oral candidiasis. And so these patients are recommended or advised to rinse their mouth with warm water after using the inhaler. We also use other therapies like the roflumilast. The roflumilast is a phosphodiesterase 4 inhibitor. And then we know that at the level of the smooth muscle cell, what it does is that it inhibits the cyclic AMP. Cyclic AMP is supposed to activate the protein kinase A, which in turn will inhibit the myosin-like kinase factor at the level of the smooth muscle to cause its relaxation. And so if you don't give, there are cases where if the 3 stages of treatment using the LAMAs, the LABAs, and the ICS are failing, you can resort to using a roflumilast, which will help to inhibit the phosphodiesterase. So you have more of the cyclic AMP, which will cause more of, smooth muscle relaxation at the level of the bronchial tree, and then hence would help in easing the obstruction. There's also, studies that have shown that the use of azithromycin or erythromycin helps in reducing the exacerbation. Azithromycin could be used 500 milligrams 3 times a week for 1 year, or you can do a daily dosing of 250 milligrams per year. Then we can also use carbocysteine and then N-acetylcysteine. These are mucolytics and then also antioxidant. We realized that, or we saw that in the pathogenesis of the chronic inflammation, there's an oxidation reduction pathway there. And so these would also help in that aspect. Then the methylxanthines, which are the aminophylline and the theophylline, which are also phosphodiesterase inhibitors, but the roflumilast is more specific because it inhibits directly the 4, but the theophylline can either inhibit the 4 or the 3. And then the other thing is that for you to use theophylline, you would have to be doing the serum levels of theophylline because of the size or the toxicities that are associated with it. And then we also do a dosification of the antitrypsin to find out if the patient is deficient or not. And then usually if the levels of antitrypsin falls below 50 milligrams per deciliter, it is recommended that you do an alpha-1 antitrypsin augmentation therapy. And so this is more of a flow chart of how the various group of medications could be used in the management of COPD. So as a way of follow-up therapy options, after the initiation of COPD therapy, it's good to follow up to reevaluate the current therapy, if the current therapy is actually working for the patient, and then to see how often the patient is getting exacerbations, and then to consider if you're either going to step up your ladder or you de-escalate or you have a reason to change the inhaler for the patient. And as a form of this, in other settings, it's actually recommended that patients who have COPD be vaccinated against influenza and then pneumococcus, because these are some of the organisms that are mostly associated with the acute exacerbations of COPD. And so the patient with COPD is advisable to give them the influenza vaccine, and then that of the pneumococcus, which is a polyvalent vaccine. In some settings, they also recommend the administration of the Bordetella pertussis vaccine. And as I was saying, the other states of treatment options are the alpha-1 antitrypsin replacement. You can have your lung volume reduction surgery just to reduce the hyperinflation that occurs with COPD, and they usually recommend about a 20 to 30%. And this one is usually when your medical therapy has failed. You could also do a bulectomy. And now COPD is a progressive disease, so it's usually good to have an assessment or to make a prognosis of the disease. And then the index they use is what they call the BOLD index, and it's used to predict the death and hospitalization better than that of the forced expiratory volume that is picked up on spirometry. And then the BOLD index also happens to be an acronym for what is the body mass index. We saw that people with COPD tend to even develop cachexia, wasting, and a lot. And so if your body mass index falls below a certain parameter, usually 18.5, as they say, you should know that this person is actually at the later or the end stages of the disease. You also use your airway obstruction, that is the forced expiratory volume in 1 second on the spirometry. Then your modified Medical Research Council dyspnea scale to assess the severity of the disease. Then your exercise tolerance, where you can use the COPD assessment tool. And so the BOLD index is very important to do to assess or give a prognosis to the patient with COPD. And these are my references. Thank you.
Wow, this was great. So if you have any question that you want to ask, kindly electronically put up your hand, and then I'll unmute you to go ahead and then ask your question. As well, if you would rather want to use the chat box to type in your question, kindly do that, and then I can read it out so that we have a discussion. So kudos, Dr. Molitey, for an excellent job done. This was great. Presenter at the level of a resident. Obviously, I'm recording this. I'm sure my respiratory consultant will be happy when I share this with her. So guys, if you have any question, kindly put up your hand, and I would unmute you to go ahead with your question so that we'll sort your question out. As well, if you have any contribution or a suggestion to make or any comment at all, kindly do so. Just electronically raise up your hand. I will mute you. Dr. Molitey has virtually touched on everything about COPD. I was particularly happy you brought something about the body index. We got that as specialist exam in 2018, and a lot of people do not know what body is. But at your level, you'll be able to excellently explain it. It's fantastic. Okay, so I'm going through the chat box since I don't see any hand yet. So Dr. Joyce says a great presentation. Aruka as well, great presentation. Aliu MD, beautiful, beautiful presentation. Well rehearsed and researched presentation. I can't agree with you any less. Hands up, anyone? I don't see any. Or you've been able to probably touch on everything, say that no one has a question. Recording in progress. Aisha says, thanks, Doc, you did great. Yeah. Okay, whilst we are waiting for search, at least we have some few minutes. Dr. Molitey, have you heard of a combination, what do you call it, inhaler called Ipralin and its constituents and its use in COPD?
Honestly speaking, during my lesson, I didn't come across anything like that.
Okay. Have you any use of budesonide in COPD? Sorry, pratropium bromide, I mean.
Yes. So I said that, they said that during the acute exacerbation of, budesonide is an inhaled corticosteroid. And
sorry, not budesonide, I mean ipratropium bromide.
Oh, okay. So the ipratropium bromide is a shock-acting M3 antagonist. And so in the acute exacerbation of COPD, it is said that it's rather recommendable to use the SAMAS rather than the SABAS because of its effectivity. Even though the SABAS are mostly used because of its cost-effective nature to patients. And so the ipratropium bromide is the commonly used short-acting muscarinic antagonist that we use, especially in our setting, in combination with the salbutamol in the acute exacerbation of COPD.
All right, great. So commonly, those patients with COPD on a regular bronchodilator, but who continue to have evidence of bronchospasm and require a second bronchodilator, we usually add the pratropium bromide to it. One of the common combinations in our country is usually the Ipralin. That comes as a combination of, can I remember what it is? I know it's a pratropium bromide plus something else, but I just have to. I think it's one of the SAMIs. I can't remember. It should be albuterol. Albuterol, yes. Okay. Okay, let me see. Yeah, so someone is asking a question. Great. Janto says, does the central respiratory areas of the brain suffer a decline with COPD? I'm asking because of the targeted SpO2 levels for oxygen therapy at 88 to 92%. Great presentation. So excellent. I'm happy that you've brought this up. Dr. Molitey, why do we tend to keep the people between 88 to 92? Is it because the central respiratory areas of the brain will suffer a decline with COPD, like Dr. Janto is asking? Or is there any other reason why we tend to have that close target?
Yeah, so the reason is that people with COPD, we know there's a buildup of carbon dioxide at the level of the lungs because of the air trapping that occurs. So basically, they're not able to expel the air that goes into the lungs completely. And so this will translate into a VQ mismatch, that is ventilation perfusion mismatch at the level of the capillaries. And then this hypoxemia that develops as a result of the VQ mismatch actually serves as a drive for the chemoreceptors at the level of the carotid and then the aortic bodies. And these are also they send signal to at the level of the midbrain. I'm forgetting the name precisely, but they are responsible for regulating the respiratory rate, which will actually help in controlling the levels of carbon dioxide at the level of the lung. So it will basically increase respiration to help the person expel the carbon dioxide. And so if you give too much oxygen, it means that you are changing this VQ mismatch. You're actually trying to correct it. And so in an attempt to correct it, you are going to depress, meaning that those chemoreceptors at the level of the aortic and then the carotid bodies would they'll be inhibited because there's no hypoxemia drive again, and so the person might go into respiratory failure.
Excellent. So the guy likes pathophysiology and physiology. Yeah. So the thing is that the simple response is that the hypoxia is needed to keep that respiratory center in check. So usually if you up them more than 94%, the risk is this hypoxic drive that stimulates your brain to allow for respiration will be blunted, and the person would have untoward effects. Sometimes you may even lose it. You're asking about the midbrain. It's called the PAG, PAG. Is the periaqueductal gray part of the midbrain. That is usually responsible for this. But obviously, the simple answer is yes, as I've stated. Great. This has been good. We've just gone past the 4 o'clock. And I see another one, learning taking place. Please, how is the hemoptysis treated? Okay, so the hemoptysis in COPD, Dr. Molitey, do you want to look at that?
I'll give it a try.
Yeah.
So I think that the hemoptysis in COPD, COPD, one of the main presenting or main symptoms is the chronic cough. And so the chronic cough could be the resultant or could be the reason for which this patient would develop the hemoptysis, because of the fact that during this process there's laceration on the mucosal surface of the respiratory or the respiratory system. And so this person will tend to have blood coming up together with the sputum. And so when we're looking at the treatment, we looked at the mucolytics. And so if you give the mucolytics to help fluidify the secretions, I think that would help reduce that or kind of treat the hemoptysis. I think that's what I can say.
Yeah, so key to it is just obviously, number one, usually you want to rule out the malignancy. A couple of those who have COPD, again, like you rightly said, have had some pack years of smoke. And so one of the key things is to rule out bronchogenic cancer. The commonest in smokers being the squamous cell carcinoma. So obviously, if somebody with hemoptysis in the setting of COPD, which, like Dr. Molitey mentioned, COPD is not one of the major signs. What do you call it? Hemoptysis is not one of the major signs of COPD. So once that sets in, although it's not an uncommon finding to have, once that sets in, one of the things that you want to rule out is it just only a COPD or there's more to it? And so when that comes up, you may need to do some further investigation, i.e. commonly the contrast enhanced CT scan to rule out a tumor in the lungs. Also looking at the various, what we call the paraneoplastic syndromes of lung cancer, specifically the squamous cell cancer. If it manifests this, you may sway more towards doing investigations in that regard. But if it is the typical things of the main cardinal things are the dyspnea, the chronic cough, and then the sputum production. In addition to this, if a bulle does open up or any of that, you can tend to have some blood in the sputum. And the management is to treat the underlying cause, except if it's massive, then there again, you need other interventions. But once you've made a diagnosis of the COPD, the management still ensues as such. Great. So let's see if there's any more. I think there are 2 more. Great presentation, Dr. George, our team. Any reflections on the extent to which COPD guidelines in Ghana are translated with regards to other health professionals, nurses, physiotherapists, and dietitians? Dr. Molitey, do you want to take a go at that?
No, boss.
All right. So recently I was at a WHO program with Dr. George. We looked at the issues regards COPD and other medical conditions that people come in as a result of air pollution, pollutants, the particulate matter and all of that. COPD is one of them that we really see. And like we mentioned the introductory remarks, a couple of people in the Western world, they will usually say that history of smoking, think COPD. In our environment, a lot of people don't smoke. We will say that in the rural setting, history of chronic cough in a woman with sputum production, you need to really take the social history very well. Otherwise, you end up losing that. And it was one of the things that I strongly put up at that workshop, that in our setting, there may be a bit of differences comparing like the Western world to ours. The typical thing is that the woman has not smoked before, and middle-aged to elderly woman, like Dr. Molitey mentioned. The only catch is that you ask about biomass, which is, of course, an indoor air pollution. Biomass, use of firewood and all of that. And they will say, oh, the kitchen, even when she goes inside, she's having difficulties, and it's probably even gotten worse. You look at the kitchen setting, if the public health people are even involved to go look at it, you realize that the window through which this smoke comes out is coated black, the soot. So I just directly, to answer your question, obviously this engagement, I think, brought together a couple of professionals, including the public health people. I know a couple of physiotherapists have been involved in lung problems as well as some of our public health nurses and the dietitians. So it's a multidisciplinary team approach. It's important, especially those of us in rural setting, to engage these people, especially with regards to the social history, to be able to pick up, rather than just the everyday respiratory tract infection. It may just be more than the respiratory tract infection. Again, with regards to the treatment, sometimes there's chest physiotherapy that is needed. The dietitians will also be needed, especially with regards to getting antioxidant diets and all of that. In the rural setting, we tend to employ more of these because we don't have those fanciful antioxidant supplements that elsewhere people have so much money that they can put in. So it's an excellent one that you've brought up there, Dr. Georgia Tim. And I'm sure this presentation will highlight the need that we need to engage all other health professionals so that then we can appropriately manage our people and then create the awareness of COPD and environmental pollution. Dr. Aruk, please, I would like to know what's the maximum amount of oxygen given per minute if you're using nasal prongs, and the minimum when using the non-rebreather mask, and why? Okay, this doesn't fall in the peril of this presentation, but I'll let Dr. Molitey take a go, because I remember we did have a chat around that at the ward. Dr. Molitey, will you want to give it a try?
Is he asking in regards to COPD or in general?
No, I think in general. In general, because in COPD we have the target, i.e.
Yes.
the 88 to 92.
Yes.
Whatever that delivers, that we don't have a problem with it. So commonly, because we're even looking at a lower target, we tend to allow them on the nasal prongs, because that, with a small amount of oxygen, is kept there. But I'm sure it's extrapolating it to use of nasal prongs versus the non-rebreather mask and the amounts involved.
Okay. So if they're using the nasal prongs, the rate at which you can give the flow is up to 5 liters per minute. And then this is because we all know the diameter of the nasal prongs. And then this also depend on the severity of the distress that the patient comes in with. So if a patient comes in and then is saturating at, let's say, 80 or below 90, and then you put the patient on nasal prongs, and then it's how do you call it? Appreciates to more than 92 to physiological levels. Obviously, you want to leave the patient on the nasal prongs. But a patient comes in and is saturating below, let's say, values, let's say below 80. You know that obviously if you use in some situations when you use the nasal prongs, it does appreciate. But if you use the nasal prongs and it's not appreciating at the maximum of 5 liters, you can switch to the face mask. And with that of the face mask, the rates, you can go up to 10 liters per minute using the face mask. And then if with the face mask, you are not able to achieve the target saturation for the patient, then you can step it up to the non-rebreather mask to a maximum flow of 15 liters per minute. I think this is what I can remember.
Yeah, excellent. So that's essentially it. Some people quote 5 to 6, any one that you want to trend with. The rule of thumb is just as he has explained. One, it depends on the setting. So like we always say, human beings we are not robots. So it depends on the clinical setting, how the person presents in. And so if you want to achieve oxygen delivery at a higher rate at the shortest possible time, obviously the use of the non-rebreather mask is one of the things that you do, because you want it to go up there to as much as 100%. The nasal prongs, another big issue with it is the fact that at that high level of oxygen delivery, the diameter of the prongs, like Dr. Molitey rightly said, it becomes unbearable even for the patient himself. And so obviously, if you're looking at delivering anything above that 5 to 6 liters, you have to change. The advantage with the nasal prong, in addition to the fact that it doesn't cover the whole face and all of that, it allows the patient to be able to eat. So those who we tend to de-escalate or wean down or taper down the oxygen amounts, the amount delivered, we tend to go down to the nasal prongs if only they are okay with that. In the setting of COPD, you realize a couple of them are on the nasal prongs because we don't want to get above a certain percentage, like has already been explained. So these are some of the things that we need to be aware of, so that then you don't go to the ward and then the nurses have put up a nasal prongs onto the person's nostrils and dial the oxygen to 15 liters per minute. Essentially, you are traumatizing the patient and not delivering, you're not using the appropriate gadget. So some of these are important. Another thing that, because it's brought up this, and we are talking about a respiratory issue that we want to be careful about, is the use of the vaporizer or the humidifier, that chamber that we put in water. Sometimes, in actual fact, we give some patients infections from the hospital, i.e. the iatrogenic infection. So if somebody is on, as excellent as the humidifier is or the vaporizing chamber is at cooling the air, at making it more bearable, the same humidifier cannot be used for for different patients. And sometimes you walk to the ward and then there's a greenish tinge on the water or even on the flow meter, and we keep using this. Unfortunately, so spirogyra or any of those things have developed on that end, and then we keep giving it to the patient. Certain is that a couple of people with requiring the oxygen therapy may have one form of immunosuppression or the other, and then we just probably promote fungal infections and all of that. So again, a key thing to be mindful about. Please be on the lookout at that humidifying chamber. Don't wait till it's green. Change it for every patient and make sure that it's usually cleaned before being used for another person, especially in this day and age of COVID, where then those respiratory droplets can easily get in there and transmit an infection. So these are some of the things that we should be careful about with practice, so that then we don't keep having these issues come up. Okay, so Betty is asking, please, how common is COPD in asthma patients? Okay, Dr. Molitey, do you want to have a go?
Yeah, I want to try. I think that COPD in asthma, I didn't actually come across any concrete statistics, but what I do know is that the literature talks about an overlap between persons with asthma and COPD in terms of the airway responsiveness, the airflow obstruction, and that of the pulmonary symptoms. And then this actually led to what they call the Dutch hypothesis, where they said that the asthma together with the emphysema and then the chronic bronchitis are three, how do you call it, the same basic diseases, which are modulated by environmental and genetic factors to produce the pathologically distinct entities. And so obviously if somebody has asthma and then is also a chronic smoker, I think the tendency or the risk at developing it, looking at already the pathogenesis of the two conditions, I think they stand a higher propensity to develop the asthma. But as to whether concrete statistics as what percentage of people with asthma can develop COPD, I don't have those numbers.
Yeah, great. So great job there as well. So there's what is called COPD, asthma overlap. Like we know, there's an underlying inflammatory condition or problem. The certain again is that because of either lack of knowledge or the fact that we don't keep updated, we fail to stop the inflammation. And if you don't stop an inflammation that goes for a long time, there will be remodeling. So in asthma, there's a background chronic inflammation. So if you read asthma, they'll tell you that it's a heterogeneous disease characterized by, there's always that thing about inflammation. If we do not use the steroids, the inhaled corticosteroids, there's no place for just using only a SABA in asthma. And it is sacrilegious to give tablet salbutamol. Unfortunately, these are the realities on the ground that people still do. So the person who has the asthma has the inflammation going on for years. The bronchioles and bronchi get remodeled and stiff, as hard as a bone. And in effect, you've ended up giving the person sort of like a COPD, such that when you use your SABA, post-bronchodilator, there won't be any change because the airway is stiff. So the key thing is that you can progress from the asthma. Essentially, like you said, the diseases, both of them are quite similar. The only difference is, of course, the fact that those who have alpha-1 antitrypsin obviously will have their elasticity impaired. Those who have asthma tend to have reversible airflow limitation. And so if it's treated well, they may stay off there, or even sometimes like people grow out of it. But if it's not well treated, the airway becomes stiff, and then you can progress to any of the forms of COPD that is mentioned. That's where then they call it the COPD, asthma overlap. It's not directly like the asthma causes the COPD. It's just a result of the fact that the risk factors are about same for both, and if you poorly manage, it can lead into the airway remodeling and giving you that kind of picture that you have. Then the good thing or the better thing about asthma is that really if you treat it well, people are kept virtually without, exacerbations for a long period of time. And so the lesser your exacerbations, the lesser you are at risk of having the remodeling, the lesser you are at risk of dying from a severe exacerbation of the asthma. So that's the factor that we usually look at with regards to COPD and asthma. Okay, great. I don't see any other comment. Okay, Jan Tao has a question. Please unmute yourself, Jan Tao, and go ahead.
Yeah, boss, good afternoon.
Good afternoon,
this is
sir.
Debo.
Okay.
Yeah, boss, my question was about the targeted SpO2 level. My understanding of COPD is that there's destruction of the alveoli leading to stiffening of the alveoli and limited airspace. So these patients are actually oxygen starved, and because the air also there's some form of air trapping, there's also increased CO2 levels. So
Yes.
I was thinking that these patients rather need more oxygen than the targeted 88 to 92%, unless they have an associated decline in their central respiratory centers. Because the normal person has SpO2 standards of 95 and above.
Yes,
so
actually 94 and above.
Okay, 94 and above. So, boss, that was my question, because I've had a discussion with a senior colleague. I don't know if I should mention his name, but I think this was the understanding I was getting from him.
Mm-hmm.
Yes,
Okay.
that they need more oxygen. So if you can tackle that.
All right. Molitey, do you want to give it a try?
Yes, boss.
Right.
I think I did mention that the reason for which the target saturation of oxygen is between the 88 to 90 is because once the patient develops COPD, as he rightly said, there's air trapping. And then together with the air trapping is as a result of the loss of the elastic recoil of the alveoli. And then we know there's chronic obstruction of the airways. And in physiology, we understand that when there is, during expiration, the airways actually tend to also collapse. So you have a chronic obstruction together with the normal physiology of the airway trying to collapse with a decreased elastic recoil of the alveoli. So there's air trapping. Now, that air trapping means that this patient is accumulating more CO2 than is getting the oxygen. And so the VQ mismatch will translate into the hypoxemia drive that we talked about. That will stimulate the chemoreceptors to to aid the patient to expel the CO2 from the patient's lungs to actually try to correct the whole VQ mismatch. So if you give the person so much oxygen, the high flow oxygen to above, let's say 94, you're actually correcting that hypoxia that is keeping the patient alive. And so you might actually tip the patient into respiratory failure earlier than it is supposed to happen.
Yes, so of course, Evans, they always say that knowledge is in the books, then also. There have been several trials that have been done looking at how much oxygen you need to put the person on and what is beneficial, and blunting the respiratory drive. And usually the consensus is that it is safe to keep them within that value, because it is difficult to be able to say who has just a peripheral cyanosis or peripheral hypoxemia with an intact respiratory center, as compared to somebody whose drive is based on the hypoxia, the respiratory drive is based on the hypoxia that he's having. Because it'll be difficult to say how long the person has had the COPD for. The rule of thumb is usually that you try to err on the side of caution, because if you flip off that oxygen to the 100%, and this is the patient that has the respiratory drive based on the respiratory center is derived via the hypoxic drive, you would be really doing him more harm than good. But like we said, especially those of them who come in with acute exacerbations, if it's just the acute exacerbation due to one reason or the other, and you treat the acute exacerbation, COPD itself doesn't drop your saturations that much. So relatively, they are stable. Those people, even once you sort out the acute exacerbation, they themselves, without being on oxygen, may be in and around the 9600. So for me, what the books say, until there's a contrary to it, is what I keep. And I go like guided by the various guidelines. The gold, which is the powerhouse in COPD, stays this same. And the other like guidelines, like the British Thoracic Society and the American Thoracic Society, go with the same guidelines. So I don't know which guidelines the senior colleague did use in saying that you should fly the oxygen off to greater than the quoted 88 to 94%, other than if he's sure that this is a patient who has an acute exacerbation and the acute exacerbation has been sorted out. If it's sorted out and the respiratory system via the person himself, like breathing, is kept in and around that or even greater than that, there's no problem. But supplemental oxygen, that's what we're talking about. You will not want to fire it off more than the quoted values that they gave. All right. So let's see if there's any more. Okay. So in the absence of any further questions, don't see any on the chat box. We want to thank Dr. Molitey for an excellent job done. And I'm sure we've learned a lot from COPD and the pathophysiology and all of that. So word to note is that please take your time and go through the social history. Our patients do not always have the smoking history, like i.e. active cigarette smoking or any of that. A couple of them may just be secondhand smoking, like he mentioned, or even the biomass or what they call household air pollution or indoor air pollution. And this in itself is quite significant. Also, take home is that somebody with COPD, usually, especially with smoking history, you would want to rule out a lung cancer as well, because the lung tumor can also give you the obstructive picture. And if he has symptoms directly related to the lung cancer, you need to investigate further. If he also has the paraneoplastic syndrome features, because lung cancers are associated with what we call paraneoplastic syndrome features. When they have any of this, you may need to go further to investigate the people. Thank you very much for joining us. We would exit, and then next week, hopefully we'll find a topic and then we'll go through. Because of the World Hepatitis B week, I'm not sure we would have a different topic rather than something about hepatitis B. I think the whole week is dedicated towards educating people, especially the general public, on hepatitis B, because the theme for this year says hepatitis B can't wait. We can't wait to eliminate hepatitis B. It's more significant for those of us who practice in northern Ghana, because our prevalence is huge. 1 in every 7 people that you meet has hepatitis B. And C is also something that is quite common in our region. So because of that, we are particularly dedicating the whole of next week to it, because the World Hepatitis Day is on the 28th of July. So kindly look on the various platforms. I usually see this. I'm sure you see some flyers in, and then we'll have some public engagement with them. Thank you very much for joining us, and God bless us all. Dr. Molitey, thanks once again. Excellent job done. God bless. Bye-bye.
Bye.